Hello, I'm Dr. Sheldon. I'm a fourth-year general surgery resident at Christiana Care, and we're going to be talking about extended duration VTE prophylaxis after colectomy. And I have no disclosures. So in the literature, the post-colectomy VTE rate is somewhere between 0.6 and 3.1%. And a variety of societies recommend prescribing extended duration VTE prophylaxis after colectomy for various segments of the population, which you could see on the slide. However, in the US, only about 1 to 10% of patients actually get discharged with the extended duration VTE prophylaxis prescription. At our institute, we do not routinely do this, so we wanted to see how many patients are sustaining clinically relevant VTEs. We did a retrospective review over 5 years for all non-traumatic colectomies done at our hospital. Patients were included if they had the colectomy done by a general surgeon, a colorectal surgeon, or a surgical oncologist. And the primary outcome we were looking at was lower extremity DVTs or PEs, which were diagnosed within 30 days of discharge on representation to our hospital. Secondary outcomes we looked at were post-discharge deaths and major bleeding events. And we excluded patients who had an in-hospital mortality, an in-hospital VTE, or were on anticoagulation on admission or discharge. So overall, we found 1,553 patients. There were a total of 7 patients who developed VTE. 5 had a malignant pathology and 2 had benign disease. There were no patients with VTE-related post-discharge mortalities. There were 2 patients who had non-VTE-related mortalities and 2 patients who got readmitted with a major bleeding episode. This table is showing the characteristics of the VTE patients organized by pathology. So the first 5 are patients with malignant disease. There were a total in all patients of 6 PEs and 4 DVTs. In the malignant patients, there were 4 PEs, all of them were central, and 2 of 3 proximal DVTs. In the malignant group, 2 people did require interventions. 1 patient required a chemo and mechanical thrombectomy with stenting, and 1 patient presented with AFib with RVR, likely due to her saddle PE, and required cardioversion. And then 3 patients required systemic treatment, 1 with TPA and 2 with a heparin drip. The 2 patients with benign disease who represented with VTE were only admitted for 1 day, discharged the next day on oral anticoagulation, and didn't require any intervention. Because the guidelines separate by malignancy and benign, we also tried to do an analysis looking at that. So in patients with malignancy, the VTE patients were significantly younger than the non-VTE patients, and the surgical approach, the open approach and APRs trended towards significance, but were not statistically significant. And the benign group, the VTE patients, had significantly longer surgeries. So in conclusion, we found a very low rate of VTE without any related mortalities, and given our findings, we think at least reevaluation of the guidelines would be appropriate. Thank you. Any questions?